You know, Lynn asked me if this was going to be a gloomy talk because it's about healthcare. And I promise that it is not going to be a gloomy talk. What we think we're doing is something that's actually transformative. It's going to help us get out of a lot of the trouble that the healthcare system and frankly the US system is in general. So that's kind of a lot of what I want to talk about is how a health system that's based here in Seattle, Washington, second largest health system in the country, is actually bringing together people from outside of healthcare to partner with people in healthcare, so amazing clinicians in healthcare to actually transform the way we provide health and talk about the reasons why we're doing that. So when I talk about the reasons why we're transforming healthcare, you know, when you think about healthcare, a lot of people think about it as a big industry. You know, some people think it's really complicated. Some people don't think it's complicated. Some people have just realized that it is complicated. So I promise that's the only one of those that I'll do. I promise. But really, what healthcare is it's about all of us, right? Because we all need health and we all need care from these incredible people who have dedicated their lives to giving it to us. And so I want to talk a little bit, when I say who are you, I want to talk about who you are, because I want to make sure that everyone sort of understands the issues that we're dealing with and what the data is showing us that we are moving into. And what that data is showing us is that we do have to change a lot about the way healthcare works today. And I'm going to talk a little bit about what we know about that as well, and then talk about some of the things that we are doing and in partnership with other health systems across the country, not only Providence, but others as well, and talk a little bit more about what we're learning as we go through that process. So I want to talk about three big things happening in the US today that are really transforming the way healthcare needs to work. So how many folks in the room right now are in your mid-30s or over? It's okay. It's okay, because I am. You know, so this red circle, that's you. That, in 2050, that is what the population in the United States that's going to be over 65 is going to look at. So the orange bar is the folks between 65 and 75. But what's really extraordinary is the two bars above it. Because the yellow bar is showing the population 75 to 85. The blue bar is showing the population 85 plus. That is a tremendous number of people, almost double the number today, that are 65 and over. Need care, need services, need support from us as a country as they age. And this isn't data I'm making up. I think you can see in the thing here, this is actually from the US Census Bureau. So definitely bringing forward facts and data here to show you this. So kind of another point of what's going on, showing why we need to transform. So kind of dividing the room in half here. Half of, this is from the Journal of the American Medical Association last year. Half of the US population already has type 2 diabetes or is at risk for type 2 diabetes. So it's half of the people in this country are at risk or already have a chronic disease. 52%, this is the heartbreaking part, 52% of those people are going to be diagnosed before they're 55. And if you take this third of the room over here, those are the people that are going to be diagnosed in their 30s with diabetes. That is something that you live with for the rest of your life. 80% of the people who are diagnosed with type 2 diabetes are diagnosed before they're 65. These numbers are trending downward, they're trending younger, and they're trending, to my next point, toward the poor. So this is the third massive thing happening in our country right now that our health system is having to deal with. And this is the growth of poor people in our country. So you can see from this slide, the top bar is showing poor folks age 65 and over, male versus female, age 18 to 64. But again, the heartbreaking component of this is kids who are under 18. And look at those numbers, 40%. 40% of the total poor people in the United States today are children. And this disproportionately impacts women. And you can see that in the chart here. So I think the fourth, sorry, I said there's three, there's actually four. So taking a look at the US globally. So this is a slide that my CEO uses when he's doing a talk that's similar to this. And this is talking about what's happening globally kind of across healthcare. So the top part is social services spend across lots of countries. The bottom part is healthcare spend across those same countries. And you can see that we are disproportionate in the world for the amount we spend on healthcare versus the amount we spend on social services. And in this study from the Commonwealth Fund, what they felt was you have the worst outcomes in the world because you spend the least on things like food and education, nutrition, and support for the young people in your communities. So when we look at that, I'm not showing this slide because after all of that, it's time to pray. I'm showing you this slide because these, like I said, a lot of what we are trying to do at Providence is work within this data, work within what we're seeing as these trends, and transform healthcare in order to not only support what's going on, but help reverse it. These are actually, this is our CEO, our original CEO from 150 years ago, the one with the big stick, of course. That's Mother Joseph and her founding team, and this is them in Alaska going to a gold mine to ask the miners for money to build the schools and the hospital needed for the city of Juneau. So these are the women that inspire us still today. And they're also the women that gave us our guidelines going forward, which was you must continue to care for your communities and not be burdened by what's happened in the past. And I think that that is a really powerful way to talk about not only sort of what we're dealing with today, but the way we are transforming to look at what's going to happen in healthcare tomorrow. So very quickly, Providence Health and Services, second largest, like I said, second largest nonprofit health system in the country. We have 50 hospitals, 106,000 caregivers, and about 900 clinics across 7 states. We're in Washington, Oregon, California, Alaska, Montana, Texas, and New Mexico. I think I got all 7 there. You know us here, if you're from the Puget Sound area, you know us as Swedish probably. We're also Pacific Medical Centers, PacMed. If you're from Oregon, mostly you know us as Providence. If you're from California, you know us as St. Joseph Health or Providence. So that's kind of a look at who we are as a company. And like I said, what we've been inspired to do is take care of our communities going forward without being encumbered by what's happened in the past. So we have a hypothesis of how we can move forward and transform healthcare, and it's really through bringing the best technology and consumer minds in the country together with the best clinical minds in the country to create new solutions going forward to solve the biggest problems that we have. So what I want to talk for the rest of the time about, because this gets to the uplifting and the more fun part of the talk, is a little bit more about some of the work that we're doing, including the work that we've done with the team at Blink, and how that is starting to move the needle on a lot of these issues that we're facing. So first off, when I said the first goal is to find the best talent. So one of the great things about being a huge health system in the Pacific Northwest is that we have some incredible companies here, and we've been able to find some incredible people to come and join us. So we have technical architects from BlackBerry. We have the founding team from a company, Swipe, which is a keyboard that's probably on most of your phones. We have folks from Amazon and Microsoft. We have architects from Salesforce. We have designers from eBay and Procter & Gamble, all together now with some of the best clinical leaders in healthcare. And these are a group of amazing people who not only they spend their days caring for people and their afternoons with us talking about how to use technology and use digital initiatives to improve healthcare. So when I say we're working to solve the big problems, this is a look at some of the products that we've created that are in use today at our health system and other health systems across the country. And I want to go through kind of how we've actually are utilizing consumer best practices in order to create those. So first off, talking a little bit about consumer best practices and design. So this is Circle Women's Health. So when I talked about, and I'll tie all of these back to the big problems that I talked about at the beginning, when you look at one of the huge issues going on in healthcare today, these issues disproportionately impact women. And so we feel that there's a small niche market called women that we actually need to do a better job of supporting. So we've created a digital tool called Circle Women's Health. And basically what it does is engage with our female patients with information that we know about her from the medical record, and ties into her wherever she is in her life. In this example, she's currently, let's see, she's got on the left-hand side, she's pregnant. On the right-hand side, she has a new baby. So it gives her information from her doctor about the frequently asked questions that she has. It gives her easy access to us, so easy ways to make appointments, easy access to find us. And it gives her information about resources in the community to help raise her family and help improve her own health. And what we're finding with this is we introduced it through our providers to our patients. And we have a usage rate on this that is about 75% in the first year, which is really pretty amazing. For those of you who have done kind of consumer launches before, being able to launch and have something utilized at that rate is actually pretty incredible. So we've been incredibly happy with it. We launched this actually initially just to support pregnancy. And what we found was when these women started having their babies, we got a lot of very negative patient feedback saying, "Where'd you go? You can't stop now. I still need all that help. We have patients who call this the doctor in their pocket." So we've expanded it across pediatrics on the way to supporting all of women's health. And like I said, are seeing some pretty incredible results from it. So a little bit more about the work, and this is a lot of the work that we did with Jeff and the team at Blink. In fact, Jeff Alpin was with us when we talked to the docs. Remember that a couple of years ago? And we brought about a dozen different clinicians together. So not only did we build this with about 100 different patients, we spent time with about a dozen different doctors and really said, what is the best thing that we can do with mobile for these patients? And this is the application that we came up with. So in terms of looking at big problems, in terms of helping an audience that needs help and is being disproportionately impacted by issues going on, not only Medicaid moms, who we see a tremendous number of on this app, but women in general and needing additional help in health and raising their families, this has been a pretty incredible tool for us. So I actually can stop there, and I want to say, if you guys want to ask any questions, please just do that. I have this pretty bright light, so I might not be able to see you, so just yell at me. Yeah, I can.
Very curious. The 75% is amazing. What was your most effective distribution strategy?
So it's when it's introduced by the clinician. So when it basically becomes part of caring for you during your pregnancy, we have a clinician introduce it to you. We also have electronic means by which we contact them. And frankly, because it's got the brand of a trusted health system on it, the patients naturally see it as an extension of their care, which it is because it basically was put together by their docs. Yeah, so we really feel, the hypothesis going into this was all of us coming into this from outside of healthcare have never seen anything like the trust that people have in their health systems and in their doctors. And we know that when we can create systems and processes around that, we can care for people better by helping utilize that brand. Does that make sense?
Yes.
Okay, yeah. Anybody? Yeah?
What percentage of your Medicaid patients have access or use this product?
So all of them have access to it. We do not have it broken down by how many people have Medicaid and are using it, but we know that the utilization rates of the Medicaid components of this are very high.
A couple of the sessions we've talked about data sovereignty and the patient or the user holding their own data and then giving it when necessary. How does Providence? Is Providence taking any steps towards that, or do they have any thoughts on that?
Yeah. So part of this app, when you actually download it and install it, we link it to your medical record and we tell you that we're doing that. So the user knows from the beginning that information that comes that's specific to them is coming from the medical record. Okay. So I keep going. So I'm going to talk about a bunch of the other things that we've got going on. So another thing that I talked about was, the increase. So we have, as more and more people need health care, we're needing to figure out more and more ways to provide them with that care. And turn up the volume on convenience. It's no surprise to us that it is really tough to get to the doctor between 9 and 5 Monday to Friday when everybody has other things going on. So we actually have worked a lot to expand our availability and the types of places that we're providing health care. So 3 different things that I want to talk about here. Urgent care clinics that have extended hours, so extended on the weekend hours and extended into evening hours. We have started the process of creating those in more convenient locations than some of our clinics are. So we're doing basically what consumer businesses have always done, taking a look at where populations are starting to build and making sure that we're getting the clinics into the right places. We actually have gotten some help from the Starbucks team to learn how they do that. So we're starting to map to some of the learnings that they have. We also have a partnership with Walgreens and have urgent care clinics. So those of you who are from Seattle or Portland have probably seen these in your local Walgreens stores. So those again have extended hours and hours on the weekends and good tie-ins to the pharmacies. So we're improving access and convenience there. And then there's 2 other things that we're doing that are, one of them is new and one of them isn't new. So how many of you actually know that for what we call a low acuity condition, like a sinus infection or the flu, that you can actually use your phone to have a video visit with a doctor and get a prescription? How many of you know that you can do that? So you can do that. You can actually, you don't have to go to the doctor to get your antibiotics for that sinus infection that you get every year that you know is a sinus infection, that you just want to be able to say, I have a sinus infection, give me a prescription. So you can use your phone now to do that with the virtual care product that we have created. And this is something in use kind of across a lot of health systems in the country. And then we've also brought back home visits. So we actually have the capability to dispatch a doctor for patients who are homebound. And this is, again, to help with the aging population. But what we're finding is, boy, do moms really like this too, because you can line up all the kids that are all sick at the same time, and you can have the doc come in and take care of it. So again, just kind of helping increase that convenience. And this is a look at the technology platform that we've built to support that. So if you want to have a home visit from a Swedish or a Providence clinician in Seattle, Portland, or Los Angeles, you can use this application, tell them where you are, tell them when you'd like the visit, and you can see here we've got Dr. Mishra on her way to help you out. The underlying medical record in all of these visits, so whether you go to a Walgreens clinic, whether you go to a Swedish clinic, whether you go for a virtual visit or have a home visit, your medical record is one record underneath all of that. So we have that consistency across that experience now, which has been a huge thing for our health system, not only because we're able to extend the ways that we can provide care, but we're also able to keep it consistent for our patients. So, yeah.
I was curious, so for the online thing, I'm guessing that it helps with getting someone that's already in network, because I know if you go somewhere and you get treated, you can't always know whether you're getting somebody that's going to be in network or not.
So when you actually use the app, you can, a part of the app is putting your insurance in, and it will tell you when you start if we can support it or not. So yeah, part of the process, and that was consumer feedback, right? Because everybody feels that same way. There's no way I can get a doctor to my house that's going to get paid for. But it turns out there's actually a lot of insurances that will actually pay for that. So we help you out right at the beginning with figuring that out.
Question.
Yeah.
Sorry.
You can go ahead. I can repeat it.
2 questions. One, this is just like a scalability thing, because it's amazing to hear this. This sort of flies in the face of everything else. Is that 2 things? How is it affordable for you to deploy home visits? And the other one is when you do Walgreens, because I've seen a lot of express clinics grow up. Who is, like, what's the level of acuity that you put at a Walgreens? Like, is it a PA or who's there that is attached to your name,
Mm-hmm.
that people feel a level of trust that they can
Yep.
go there?
So first question was, how are we making home visits affordable? And second question was, what's the level of the clinician in the express care clinics?
Yes.
So first question, how are we making home visits affordable? So this is actually part of the kind of peanut butter and chocolate magic that I was talking about. So when you think about some of the people who have come to Providence to help us build this out, these are people that built huge infrastructure systems at Amazon. These are people who have built out huge infrastructure systems at Starbucks and Nordstrom. So basically what we have done is use their knowledge of how to create extremely reliable and efficient systems and put those on top of what we're doing with the clinical side. If we did not have that, there is absolutely no way we could have made this affordable. But utilizing their knowledge helps us get to the point where we can afford to send the doctor to the home. I mean, to be totally honest, it's been about other people from outside of healthcare coming and building this. The second question is, who are the practitioners at Walgreens? I don't know if this is 100% of the time, but I believe they are ARNPs. So they are not MDs. They are nurse practitioners who have the ability to prescribe. Yep. Okay. Yeah.
I have a question about the notion of the technology, and do you feel that you're missing people that maybe, you talked about like the demographic of the Medicaid or people like that who just, health is like the last thing they think about because their other basic needs need to be met. And if maybe what approaches, if any, are you guys using to tackle that? And you know, I know you mentioned the Commonwealth, looking at how other people are utilizing that to empower kind of the healthcare spend.
Yeah. So, you know, a lot of the work that we're doing on where to place these clinics, and this is, I'm sorry, I keep coming back to this, but this is an example of how folks from outside of healthcare are helping as well. So when we're taking a look at populations for the first time now, taking a look at where people live and who they are, and really taking a look at who needs that access. So where do we need to work with Walgreens to put a clinic? Where do we need to put an express care clinic? Where do we need to turn up the volume on where we're marketing the virtual visits to make sure that we're appropriately covering that section of each of the communities that we're in? It's not something that we've ever done before, but it's something that consumer industry is teaching us how to do. Okay. So kind of for the next one, to talk a little bit more about some of the underlying technologies that we're creating to help. In a lot of cases, these actually help. We always say it's incredibly important for us to work with patients. I actually feel it is equally important for us to support our caregivers. I don't know how many of you are related to folks who are in the medical field. You know, they're not the happiest folks right now. And it's heartbreaking to see what they do every day and then see how hard their jobs are. And, you know, technology in every other industry has helped make people's lives easier and helped make work easier. We really need to turn up the volume on that and improve lives for our clinicians. So this is an example of a product that we're creating. We call it a digital prescription engine. And this, in terms of big problems that we're trying to solve, is a response to lots and lots of patients coming to us with, you know, Fitbits and different applications and other things that the docs have no idea whether they're actually true applications, whether they actually work, whether they have any clinical relevance at all. And so we're basically trying to turn that over and say, if you come to a clinic and we diagnose you with diabetes, or we tell you that you need to have a CPAP machine, our docs are going to prescribe that tool or that machine to you through the Zelf engine, and then they're going to be able to watch you using it to make sure that you aren't having any troubles with it, to make sure that you're complying with the care plan, and help you out if you need to on an ongoing basis. A big part of the effort that we're doing here is how can we basically extend our clinicians' reach beyond when they're with that patient in the clinic. A little bit more about how Zelf works. I think, you know, again, back to the idea that this was built by people from outside of healthcare. This is actually the tool that was built by the founding team of Swipe. And they came into healthcare, spent about 9 months with us really kind of looking at how could we solve one of these big problems, and came up with what I think is an incredible idea, which is the development of this, and we're actually in process of deploying it at Providence right now. And again, what we've shown is when you get asked to use a diabetes management app, or the Circle app is actually another thing that's being deployed through this. If that note comes to you from your doctor, or if that's part of your visit to your clinician, you're going to use it. And so the results these guys are seeing are actually pretty incredible in terms of compliance. So related to, but separate from this, we do a tremendous amount of work in talking to patients about what some of the big problems that they're facing are. And one of the things that we hear over and over again when we talk to folks who have chronic disease is, I got this diagnosis from my doctor, and then I got a couple of pieces of paper, and then I was totally on my own. And you told me I have to change my entire life, and I have no idea how to do that. And the internet isn't helpful to me because it's not culturally relevant. The things I'm finding there are not culturally relevant to me, and they don't support where I am at a socioeconomic level. Even these drugs that you gave me, I can't afford. They're too expensive. So basically what we're doing with CareIQ is tying that diagnosis to a socioeconomic profile of that patient through utilizing the data that you guys have all used before to find more information about somebody. So we're finding out about where they live, we're finding out about what some of their background might be, we're finding out about their cultural preferences, and then we are customizing that ongoing care plan to them so that we can help support different demographics with managing chronic disease on an ongoing basis. And this is another example where this is clinicians introducing this program. But patients, basically what it is the equivalent of is, you know how on Amazon you guys get that customers who bought also bought? So when a patient basically says, when we say to a patient, this is what other people in your neighborhood, or this is what other people like you, this is what works for them, what we're finding is, oh my gosh, okay, that's people like me, so I'm going to do that too. And we're seeing social groups actually start to be created around that so that patients are actually helping themselves. So some pretty incredible work going on there. Again, by utilizing just some data from consumer industry that was out there already in a new and different way. So any questions on those? Yeah.
I'm starting, it's shocking being on the East Coast, which has the worst healthcare. Doctors are so against all of this, or hospitals resist it. How did you get over that culturally within a healthcare system?
Yeah.
I'm serious.
No,
because
I know.
I have a CPAP machine, and I would love someone to read the numbers and tell me. I would like to not discover that I'm losing oxygen myself. I would love it, but there's no mechanism in place, and there's a lot of resistance from administration to clinicians.
So the question is, how do you make these cultural changes inside the facilities? Because you're right, this can be seen as a threat. I mean, particularly things like telehealth and other things, right? Yeah, who are you guys, right? But I think, a big thing that we're doing and something that we know is different from the way we've done this versus how other systems are doing it is we partner from day one with clinicians themselves. So we actually never start a project when we don't have a physician champion on the project, and we always make sure that that physician champion is someone who is very notable and who people, as you know, it sounds like, there are some of them who everyone follows. So we make sure that we are working with clinician leadership in order to develop and deploy, and then we deploy very small scale. So we take the risk out of this by deploying in very small scale, showing the proof, expanding, showing the proof again, and then keeping going from there. And frankly, we're also making their patients happier and their lives a bit easier. So we get a lot of support because of that. So, sorry, yep.
Yeah. Are you doing anything to capture medical records that are outside of your system?
No, not really. I mean, we can't really do that. We can, I think there are ways that you as a consumer can do that and pull it together. I think they're super complicated and have lots of things to do with blue buttons and lots of money and stuff like that. But no, we utilize the records that we have for patients.
On that topic, how easy do you make it for patients to get their own medical records in some sort of portable form?
So, that isn't an area that I focus on. I know that there is a lot of legislation around how we can and can't do that. That makes it actually pretty tough to do. It's an area that as we take a look and as we take a look at some legislative change that we know needs to be made, and again, kind of bringing people from outside of healthcare and to look at that in a different way, it's part of the agenda that we have going forward to make sure that gets easier. Because frankly, it's kind of ridiculous now how hard that is to do. Yeah. Oh, got it, yep.
So my question is, one of the things that I would be fully concerned about using the system as a patient is I take a pretty powerful drug that's called a controlled substance, Lyrica, and there are certain laws that prevent me from being able to reach a doctor out immediately and being able to get refills at certain points of time. Mm-hmm. So what types of things are you doing to help enable patients to be within the realm of legal, to not be able to get their prescriptions, and in my case, like walk around, because without it I can't walk?
Yeah. There's a lot that the medical record does to help us with that, but it is an issue with home visits that we have had to take a look at, right? So how do we know and make sure that those prescriptions are happening in a timely and an effective way? And that's actually one of the major reasons to have that underlying medical record be consistent, because then we can make sure that you have a consistent experience, whether you're with us on video, whether there's a doctor in your home, or whether you're in one of our clinics, or whether you're at a Walgreens store, right? So we're working to drive consistency there, and use the rules that are provided to us by the medical record in order to do that. Yeah.
Yeah, I had a question about legal as well, in terms of just, it seems like there's a lot of legal requirements that might have to be overcome in terms of delivery of information and accuracy of information and interpretation of test results and accuracy of diagnosis via video chat. So I'm curious if you have any advice about working with legal and how ideally legal obstacles were overcome.
Yeah, and I think that legal obstacles were overcome by what we kind of call separation of powers. And that is really, even though we work very, very closely with the clinical teams, I never should be doing anything with the diagnosis. That needs to be done by somebody who has the proper credentials to do that. We're very, very careful along the process of all of the development of what we're doing to make sure that when we are working on something that needs medical expertise, that is actually created by somebody who has that medical expertise. In fact, we have a few people on our team who are actually combo developers and MDs. So they actually, in a lot of cases, actually will take that and do that work for us. Not to discount what you're saying, because there are tons of legal issues that we have to deal with around this. And in fact, legal issues, to be honest, can sometimes double the amount of time it takes us to do this work. That is one of the unfortunate parts of what we're doing, but we also know that there are really important reasons to have those regulations in place. But it does take longer, and we are very, very careful along the way. Okay, yeah.
Hi, I was wondering, where I live, there are many hospitals that are part of considered the same network, and when you email one doctor, I didn't realize that all the other doctors in the entire network can see that correspondence. And in addition, I guess I was wondering, and I don't know if that exists, it sounds like yours is much more comprehensive and much more customer focused than what I've experienced, but and as someone who has medical issues and has learned to advocate for herself, because they can see the correspondence and they can see that I'm shopping for doctors, they've also told me you can't see more than one doctor. And I've had to actually say, I'm not the just because you're reading about me online is not who I am. I mean, you can't assume that because someone's prescribed me something that that's what I'm taking, or that I'm hopping in from doctor to doctor because I'm a druggie. And I guess I was just wondering, I've been wondering where the HIPAA laws fall into all of that, the information, being able to see the entire correspondence from doctor to doctor and see your entire history and the assumptions. It's almost like becoming managed care.
I'm not sure what your situation was there. The private correspondence between you and a doctor should actually have been kept private. So I'm not sure what the issue was there. So to be honest, I'm sorry, I can't comment because I don't really know what that situation was. Yeah. You know, that's the first time I've heard that. Private, I mean, that's part of the HIPAA laws. And again, I don't know what your situation is, so I can't really say. But if you expected that conversation was private, and you were told that conversation was private, I'm not. Again, I probably should just stop. I think if we can let's keep going, because I think I'm not sure what you guys have got for time left for me. But so again, kind of going back to big problems that we're trying to solve and taking a look at that first chart that I showed with the aging population and the number of people who are turning 65 and over. And in fact, actually, one of the statistics that I like to talk about is, how many people do you guys think a day in the United States are turning 65?
8. 8 an hour.
But how many a day? How many a day are turning 65? It's 10,000. 10,000 people a day in the United States for the next 15 years are turning 65. So that is again, kind of back to that chart showing just a massive shift in the demographic and a massive shift in the need for what a healthcare system has to provide. So when we actually started looking at this problem and started talking with seniors in our community about how we could solve it, one of the things that we found was when we started talking with senior citizens about what their needs were, their answers were not medical. Their answers were, help me stay in my home for as long as I possibly can, help me make it safe so I can do that, have someone come and cook for me the way that my family used to cook for me, and keep my kids away from me. They're driving me crazy. So basically what we did with this was say, wow, that's a completely different type of product that we've ever built. But what we can do as Swedish is have our doctors, when they see a patient who's 65 and over start to show signs of decline, refer to a service that we call optimal aging. And with optimal aging, what we have done is go out into the community and partner and contract with home care agencies and transportation companies and home safety organizations and social programs and services, and basically create a program for these patients where we can actually put these folks in their home. And these folks do everything from help with diabetic care to support for people coming home from the hospital to daily or weekly cooking services. They do honey-do lists. They support putting in shower bars and taping down rugs and making things safe. And what we've seen with this program is just a tremendous response to it from the seniors in our community, and frankly also from our clinicians, who up until this point had nothing they could do when they saw a patient who they've been seeing in many cases for years and years start to decline. So now that they have this program that they can use to help support this patient going forward, it's something that they feel very strongly and have been hugely supportive of us as we've been deploying this. First in the Puget Sound, so we support all of King County at this point, and we're expanding into Oregon and California next year with that. So it basically is an example of kind of how you bring customer service best practices into healthcare. So we hired basically a small call center of social workers who basically sit in the offices with me and answer calls from seniors and deploy these services out into the home. And we're in process of scaling that now. So a little bit more about some of the work that we're doing to support our clinical teams. So one of the things going on, again, with people aging, with rural communities starting to get smaller and smaller, and a lot more emphasis being put on the urban communities, is we have a lot of ERs out in these out in these rural communities that need specialist support. So we have actually created a an expert-to-expert video consult service that allows, in this example, a Walla Walla stroke victim who needs immediate care, but that immediate care has to be provided by a neurologist. There is not a neurologist on staff at this hospital in Walla Walla. So they teleconsult up to Swedish Cherry Hill here, do that teleconsult, and are able to provide that treatment. And the work done with that is basically, how do you take a clinical visit that normal happens person to person and get the right tools and processes and procedures in place to be able to make that a visit that can happen via a video connect. And it's amazing to watch the team that does this work of transforming healthcare from face-to-face to virtual, how they do that. It's pretty great stuff. And this one is one that we like to jokingly talk about as blood selfies. So I know that's kind of but basically surgical blood loss is actually a gigantic problem in our facilities, and the need for transfusions. In many cases, a transfusion is given when it's not needed. So there's a lot of waste that happens in the surgery room. What the team at Gauss has done, this is actually something that was created by a company that we've invested in. What they've done is basically create an FDA-approved device that takes a picture of a sponge during surgery and actually accurately knows how much blood is on the sponge, so that for the first time, our surgeons can actually know, have an actual, rather than a guess, have an actual real-time indication of the blood loss during that surgery. And this is something that when our clinical teams took a look at this, really they considered it just total voodoo. They were like, there's no way that a digital photograph can do that. But then we actually brought in some folks from the team who created the camera for Apple and talked to them and said, is there any way that a digital photograph could accurately look at surgical blood loss? And they were able to tell us absolutely. And so that was the way that we were able to work with the clinical teams to say, technology can actually solve this problem for you, and folks who have done this work before are helping us figure that out. So one of the things the team at Blink asked me to talk about is a little bit about what we've learned about innovating in this organization. I think some of these we've actually already talked about, either earlier in the talk or as part of the questions. I think the biggest thing that we know we need is to share common goals. We all know what is happening to our healthcare system, and we all know where those biggest problems are. And we're all learning where the combination of clinical expertise and technical expertise can come together to create those solutions. So take the right risks and fail fast. Jeff said I used to be at Amazon, and I saw, was it yesterday or day before yesterday, AWS came down. And I was like, wow, I remember when I thought that actually was a really big problem. Because when, in the world I'm in now, if we screw something up, it actually really matters. We can't mess this stuff up. So we do not take risks. We're extremely careful in what we do. And we make sure that we pilot at a very small scale and prove and expand from there. Because you just can't mess this stuff up because it matters here. Respecting boundaries. So I talked a little bit about really understanding where technology stops and where medical expertise has to pick up. And it also works the other way. Our clinicians are learning how far that they can push us in terms of technical questions and technology understanding, and we're finding the right middle ground there to be able to create some pretty powerful things. We have an enormous amount of support from our CEO, Dr. Rod Hochman, and our president, Mike Butler. They know that this is not a short-term issue or a short-term problem to solve. They know that we need to invest in this, invest in it long-term. In fact, we have some of the largest investments in digital technology of any health system in the country. And again, because of where we're based, we're actually able to do that, which has been really pretty incredible. And then, like I already said, we just know that we have problems to solve that are going to take a long time to solve. So we're in it for the long term here. So I don't know, am I at time, Joe?
I think we've got to the end of the time period, so let's all thank Mary for this presentation.